Hello everybody.
Hello.
Welcome to our couch conversation. I'm here in Freiburg, Germany on my couch, and on his couch in London, Ontario in Canada is my good friend and colleague Richard.
Great to be here.
Hi Richard. It has been quite a while actually since our last couch conversation.
It's time to get chatting again.
Yes, great.
So Georg, it seems that sometimes we just can't get things right. It seems that some people think on the one hand we give people dangerous exercises to do, and other people think that we stop people doing benign exercises and activities and movements. So either way, we sort of in the eyes of other people we're not doing the right thing. So what do you think about that? Maybe we start with thinking about some of the dangerous exercises we give to people. What do you think about that?
Yeah, that's actually really funny. So the McKenzie folks seem to be strange with this about the dangerous and the harmless exercises or movements they recommend or not allow or whatever. So actually it might not be only a McKenzie thing. So it comes to my mind some years ago when I flipped through the internet. I found a website of I think it was a Swiss chiropractor association, and they had a blacklist of dangerous exercises for the neck, exercises you should never do. And there were some really dangerous exercises like one of the most dangerous ones was
that's a classic. So I have an example of that. So I was on a course once, and it was a big course, and so we were talking about cervical extension, and one of the therapists put their hand up and says, I can't do that with my patients. And I said, why can't you do that? He said, it's banned in our clinic. we have a notice in the staff room. So do not give your patients cervical extension exercises because it is dangerous to do. Yes.
So how did you react? What did you suggest to this act?
I suggested he quit his job and went to go to work somewhere else.
Yeah, good point actually. Yeah. So let's come back to the topic of dangerous exercise. I think first of all, I think that the term dangerous might not be appropriate. So what's dangerous? Is that it's as a life-threatening thing? Is that a movement that brings a lasting negative result on symptoms or function? So actually, when we talk about dangerous, I think it's kind of, we should be careful and really rethink what is meant by dangerous.
Yeah, I mean, I think for me it conjures up obviously a death or serious injury for someone, not just making someone worse for a few days, exacerbating their symptoms, but for me it's much more extreme than that.
Yeah. So do you think there are exercises that can have a detrimental effect actually?
Yeah, I mean, again, I would be sort of reluctant to use the word dangerous, but I would say there are some exercises we need to be cautious about in certain populations. And the two which seem to come to mind is when somebody has osteoporosis. You know, I think we do need to be cautious with certain movements, flexion being probably the one we need to be aware of. You know, if these people have got, or they're obviously at risk of getting anterior compression fractures.
And there is some evidence on this.
There is some evidence on this, that's right. So I would say, yeah, we do need to be cautious about that. I mean, practically, can someone, avoid flexion in their everyday activities, which I think some people are advising. I would say that's really unlikely someone's going to be able to do that. But I do think caution is warranted. And the other example which comes to mind is people with rheumatoid arthritis, who actually quite commonly have changes in the upper cervical spine, and their dens is unrestrained or less restrained, and obviously that can potentially compromise the spinal cord, And the movement which seems to do that more is flexion. And of course, when we also retract, we're flexing the upper cervical spine. So I would say there's a caution with that as well. We need to be very careful about, monitoring symptomatically. And if somebody's got rheumatoid arthritis, we're not going to get in there and start, bashing away with retraction, I would say, just with that knowledge in mind. So that's another occasion where knowledge of pathology is useful to know.
So thinking about, but there is some actually, people are a little bit, or some people are concerned about, for example, extension, which is quite commonly prescribed by not only MDT clinicians, but it is prescribed. It's a common movement we clinicians prescribe in the cervical spine and in the lumbar spine. Yeah. So, and there are also some concerns about, I remember a lecture I attended some years ago where the speaker was talking about the post-Mackenzie syndrome of people who have done tons of extensions in their spine, both areas, and they ended up having an awful instability because of all these extension exercises.
Yeah, I came across something similar from a very well-known person speaking about the kind of silent effect, long-term effect of doing extension in the lumbar spine on the facets, that it was kind of going to bash away and damage these facets. And so actually I pointed out at the time that most of the time for people practicing MDT, we only give extension for someone that actually feels better as a result. And he said, this can be a silent effect, and you don't know the long-term effects on the facet joints. But we do know that generally joints like to be loaded, intermittent loading regularly throughout the day. And even that, when we give someone extensions, only in sort of the early stages anyway, it's not going to be.
So it's more about assumptions about based on biomechanical considerations, and there is no robust evidence which is actually telling us be careful with these exercises.
Yeah, that's right. And coming back to the cervical spine, I mean, we know that there have been studies on blood flow and cervical movements, but we're talking about normal cervical movements here, rotation and extension. We do know that rotation is likely to have a bit more effect than pure extension, but even so, I mean, I think the emphasis is really on, we don't need to avoid these things, we just need to do our due diligence in history, ask the right questions, monitor the response as we're going through any of these procedures, and I think then we're on safe ground. So I think,
and the beauty of the system is that we ask patients to evaluate what is going on with these exercises and what is the effect, and gives them a lot of responsibility, and they can decide, do I go on with this exercise? How does this feel? And if something is getting worse or symptoms are aggravated, they can stop.
Yes, that's right. It's totally within their own control. They're doing the movement, and as I say, we've screened in the history, and we're asking about symptom response, and also any signs of dizziness or any other symptoms that would make us cautious as we go through. So yeah, I think calling these movements dangerous is unjustified.
Yes, that's true. But getting a little bit more into the details or into the basics here. So thinking about directional preference. So we know that many patients, many lumbar patients, show a directional preference of extension. Mm-hmm. So would you tell these folks to avoid flexion if extension makes them so much better? Because that is a common idea. If one movement makes you better, you should avoid the other one, which is kind of counteracting the good one.
So in principle, you would say, yes, for sure, you do lots of one movement, don't do any of the other movement, and then you will get sort of the optimal response. And I think, and I know we've kind of said this before, but it's really about the patient in front of you. So if that patient, if you flex that patient and find that gives them back their leg pain, they get the numbness in the foot, and the more they flex, the more that increases, and you've done 3 or 4 flexions and that's the case, I think that sends a clear message that temporarily that person is probably better off avoiding flexion. And I think as long as you couch it in a way that this is a temporary thing, there's nothing wrong with bending over forward, but just for now to get some progress with this is something you're probably going to need to cut back on. Whereas, as opposed to someone in the session who flexes and flexes 10 repetitions, 20 repetitions, doesn't do anything. They report at home, I can bend, it doesn't seem to make any difference to me. Then how much are you really going to be fervent about you must not bend in order to get recovery? And so I think that there are different scenarios with the
sure
response.
Yeah, and we always have to be aware of our bias, of our potential bias. So it is a nice story I had with a patient some years ago when I had a back pain, showed a nice directional preference for extension, and he got better in I think 2 or 3 sessions. It was really good. So he was quite acute at the beginning, but then his back pain disappeared with the extension exercises. And I think it was at the end of the 3rd session he asked me, "So Georg, I'm really fine now with my back, but I feel that I'm so fat. Can you just show me some exercises for my abdominals, for my abs? I really want to strengthen them." And I was a bit reluctant, thinking about, this guy just recovered from a derangement, extension was so beneficial for him. Should I really go into flexion? So I showed him some crunches, flexion exercises for his abs, and I recommended, okay, Carl, this seems to be a good idea for your abs, but if it's getting worse, just stop it. And he said, yeah, okay, I will do that. So the next morning, by coincidence, the company of Carl, they were working in front of our clinic, and they were actually preparing the walkway with some of these small stones. And in the morning when I came to the clinic, Carl was standing there and picking up all these small stones and handing them over to a colleague. Good morning, Carl. How are you? Fine. Then I went for lunch 3 hours later, 4 hours later, and Carl was still picking up these stones, bending forward again and again. And then in the afternoon, I was just opening the window and having a look at the street, and Carl was still picking up the stones. And I was just shouting to him, "Carl, how is it?" "I'm fine, thanks a lot for asking." And I'm an idiot.
Thousands of flexions later.
Thousands of flexions. And I'm an idiot, and I was concerned about 10 flexions in lying, strengthening his abs. So it's always, you always have to test your theory with reality.
Mm-hmm. That's right. It's all about the patient in front of you and
yeah,
how they're thinking and how they're responding, and taking that into account.
So I think there's some. It's good to talk about this idea of are there dangerous exercises, and are there harmless exercises which we actually kind of don't allow folks. So we should always question our own bias with this.
Of course, yeah. And at the bottom of it, we always need to be aware of what impression we're giving to the patient. Not only just what we say, but what we do and how we act within the session. And oh yeah, you need to stop that movement. You know, yeah, it's gonna instill fear. So we really need to be aware of that for sure.
Absolutely.
Great. Okay, good talking.
Thanks, Richard.
Okay.
See you soon.
Thanks, everybody.
Bye, everybody.
Bye for now.